Hello and welcome to this non-CME educational program entitled Epithelial Cytokines and Chronic Airway Diseases, a closer look at chronic rhinosinusitis with nasal polyps. We are honored to have participants from across the country in attendance, not only in this room, but also viewing online. This program is provided by Integritas Communications and supported by an educational grant from AstraZeneca. A few important housekeeping notes for those of you in the room. To answer polling questions, please use the keypad provided. Your responses are anonymous and very important to the outcomes of this program. Program information, presentation slides, and a link to valuable clinical resources are available in the workbook and on the postcard in front of you. As part of our ongoing efforts to evaluate impact and refine future activities, please complete and return the evaluation form before you leave. For everyone joining us online, the system will prompt you to answer polling questions, and the information presented is located on the right side of your screen under the Handouts tab. The evaluation will automatically open in your web browser following the conclusion of the program. For our live audience, please use the question cards located on your table to ask questions. Ushers will be collecting them throughout the program. If you are online, please submit questions through the Q&A box on the right side of your screen. Now, let's give a warm welcome to our presenters. Dr. Kathleen Buchheit, Dr. Joseph Hahn, and Dr. Flavia Hoyt. Enjoy the program.
Hello and welcome. Thank you all for joining us as we discuss the epithelial cytokines and chronic airway diseases. We're going to take a closer look specifically at CRS with nasal polyps. So here are our disclosures. And in terms of our educational objectives, we'll describe the contributions of epithelial cytokine signaling to the pathogenesis of CRS with nasal polyps. We'll evaluate patients with CRS with nasal polyps, talking about symptom burden, disease phenotypes, and effects on health-related quality of life. Discuss clinical profiles of current and emerging biologic therapies, including anti-TSLP agents for patients with CRS and nasal polyps. And then talk about tailoring treatment regimens for these patients based on symptoms, endotypes, treatment goals, and comorbidities. So let's start out with some pretest questions. You have your audience response. So first question is approximately how many patients with CRS with nasal polyps do you manage each week? Answer 1 is 1 to 5, 2 is 6 to 10, 3 is 11 to 15, 4 is greater than 15, and 5 is I do not manage patients with CRS and nasal polyps. Okay, perfect. Next question. Which of the following plays a key role in orchestrating the upstream activation of both type 2 high and type 2 low or non-type 2 inflammatory pathways in upper and lower chronic inflammatory airway disease? Number 1, TSLP. Number 2, interferon gamma. Number 3, IL-17. And number 4, IgE. Moving right along, pretest question 3. Which of the following factors would support the recommendation for starting a biologic therapy in a patient with recurrent CRS with nasal polyps? 1, a low FeNO. 2, history of balloon sinuplasty. 3, nasal polyp recurrence 1 year after ESS. And 4, low blood eosinophils. And ESS is endoscopic sinus surgery. Okay, next, which of the following phase 3 clinical trials is evaluating the role of a biologic that blocks TSLP for the treatment of patients with CRS with nasal polyps? 1, Anchor 1, 2, Orchid, 3, Waypoint, 4, Contrast NP. Next question. Nicole is a 35-year-old woman with a history of severe uncontrolled CRS with nasal polyps who has undergone 2 endoscopic sinus surgeries. She is currently using intranasal corticosteroids and oral prednisone 7.5 milligrams daily, but she still reports significant fatigue, nasal pressure, and loss of smell that negatively impacts her quality of life. Which of the following would you recommend for Nicole at this time? 1, add on a biologic therapy. 2, add on a macrolide antibiotic. 3, repeat her surgery. 4, increase her dose of oral prednisone. And next question, approximately how often do you currently recommend biologic therapy for patients with uncontrolled CRS with nasal polyps? 1, never. 2, 25% of the time. 3, 50% of the time. 4, 75% of the time. 5, 100% of the time. And 6, I do not manage patients with CRS with nasal polyps. And lastly, approximately how often do you currently utilize the SNOT-22 questionnaire to determine symptom burden and guide therapeutic decision-making in patients with CRS with nasal polyps? 1, never. 2, 25% of the time. 3, 50% of the time. 4, 75% of the time. 5, 100% of the time. And 6, I do not manage patients with CRS with nasal polyps. Thank you for answering those. So we'll move on to our informational session, and you'll see those questions again. So let's see how much we learned tonight. So starting off, epithelial pathophysiology in the upper airways is our first section. And what we like to think about is kind of what the pathophysiology translates into from clinical symptoms. So the pathophysiologic processes include epithelial inflammation, airway hyperresponsiveness, and abnormal mucus production. And this will affect upper airways as well as lower airways, and this will result in clinical symptoms. So when we're talking about CRS with nasal polyps, these symptoms are going to be your typical symptoms of hyposmia or anosmia. When we're talking about chronic sinusitis, it's actually greater than 12 weeks, so facial pressure or pain, sleep disturbance and fatigue, which is has a big impact on quality of life, and then anterior or posterior rhinorrhea, so postnasal drip or rhinorrhea, and then nasal congestion or obstruction. So these are our major symptoms. And trying to think about these patients, we've moved from thinking about phenotype, does the patient with CRS have nasal polyps or don't they, to looking a little deeper into the endotype. And the difference here is the endotype really looks at the mechanism underlying the inflammation, and that then translates into symptoms and to clinical presentation. So when thinking about CRS, both with and without nasal polyps, we think about 3 different endotypes, type 1, type 2, and type 3. As you all know, so type 1 inflammation is going to be more characterized by ILC1 from the innate immune system and Th1 from the adaptive immune system. And then the key cytokine here is going to be interferon gamma. And the key cell is going to be the neutrophil. Type 3 is going to be ILC3 from the innate immune system and Th17 from the adaptive immune system, with the key cytokine being IL-17 and the key cell being the neutrophil. And then I left type 2 for last because, again, this is kind of the majority of our patients. Type 2 endotype rather is going to be ILC2 from the innate immune system, Th2 from the adaptive immune system, and the key cytokines are going to be IL-4, IL-5, and IL-13, with the key cell type being the eosinophil. And we know that this subtype really tends to be the one that's associated with the most comorbidity, with asthma, more anosmia, more allergic rhinitis, and these tend to be the patients that have the worst disease, the ones that have comorbid upper and lower airway disease. And so this study here is interesting. It was done in the United States, so the breakdown may be different if it had been done in Asia or in other countries. But what you see in red in the top panel is going to be the patients with strictly type 2 inflammation. And so looking at the left, it's going to be all chronic rhinosinusitis, and then it's broken down to chronic rhinosinusitis without nasal polyps and then with nasal polyps. And so the first thing you notice is that it's not just the patients with nasal polyps that have type 2 inflammation. That's also very prevalent in the patients without nasal polyps. But what's more important, I think, is that there are a lot of colors on this wheel. And if you look at the guide, it's not just you have type 1 or type 2 or type 3 inflammation, but most of these patients have a mixture of these inflammations. And on the bottom panel, you can see in magenta the patients who have any sort of type 2 inflammation. So it doesn't have to be strictly type 2, but some component of type 2 inflammation, again, is quite prominent. The largest percentage is going to be in the CRS with nasal polyp patients, where 87% have type 2 inflammation of some sort. But even the patients with CRS without nasal polyps, you have 55%. And then importantly, there's a subset that doesn't have type 2 inflammation. So keeping in mind that not every patient that walks through the door with chronic rhinosinusitis is going to have that type 2 inflammation. So about 1/3 will have mixed or non-type 2 components. And so next we're going to see 3D animation kind of looking at the pathophysiology and inflammation that underlies chronic rhinosinusitis.
The epithelium, a key component of the innate immune system, provides a physical and immune modulatory barrier. It acts as a border between the external environment and our tissues and functions to maintain homeostasis while defending against pathogens, pollutants, toxins, and allergens. This defense is provided not only by the physical barrier given by epithelial cell tightness, but also through antimicrobial peptide production, mucociliary clearance, mucus production, and permeability regulation. When the epithelium is damaged, pathogens, allergens, and other irritants can penetrate the barrier and induce innate and adaptive immune responses. A defective epithelial barrier has been found in many conditions, such as atopic dermatitis, asthma, allergic rhinitis, chronic rhinosinusitis, eosinophilic esophagitis, and inflammatory bowel disease. In response to stimulation by microbes, allergens, irritants, or cellular damage, epithelial cells release various cytokines termed alarmins, including thymic stromal lymphopoietin, or TSLP, interleukin-33, and interleukin-25. These alarmins are the body's ubiquitous warning signals following infection and physical or immunological insult. They are produced by both immune and non-immune cells and play a pleiotropic role in promoting the development of inflammation. Once released from the epithelium, the alarmins can activate and modulate innate and adaptive immune responses in overlapping but distinct ways. Alarmins are involved in both allergic, eosinophilic, or type 2 inflammation, and non-type 2 inflammation, including structural changes. They trigger activation of dendritic cells, which initiate the differentiation of naive T cells into T helper 2 cells. Alarmins also activate type 2 innate lymphoid cells, referred to as ILC2s. These ILC2 cells, as well as Th2 cells, produce copious amounts of type 2 cytokines, namely interleukin 4, 5, and 13, and propagate type 2 inflammation. The development and maturation of eosinophils in the bone marrow is regulated by several key cytokines, including IL-5. IL-5 is critical for the differentiation, migration, activation, and survival of eosinophils. IL-13 and IL-4 act on the epithelial cells to induce mucin production through goblet cell hyperplasia and basement membrane thickening. IL-13, in conjunction with IL-4, is also responsible for proliferation of fibroblasts and airway smooth muscle cells that may contribute to nasal polyp formation in patients with CRS. IL-4 is also a potent inducer of the differentiation of T helper 2 cells, monocytes into M2 macrophages, and B cells into plasma cells producing immunoglobulin E, or IgE, that then activate mast cells, perpetuating the inflammatory cascade. Macrophages promote excessive cross-linked fibrin deposition and tissue remodeling, while IgE binds to the Fc epsilon receptor on the mast cell, activating release of its contents from secretory granules, including prostaglandins, leukotrienes, and histamine, as well as the type 2 cytokines IL-4, 5, and 13. This further amplifies inflammatory loops and sustains existing inflammation. Collectively, these cellular and molecular immune responses further contribute to the disruption of the nasal epithelial barrier that ultimately results in increased mucus production and water retention, increased microbial burden, and tissue remodeling that lead to the formation of nasal polyps. Type 2 inflammation, as just described, is responsible for much of the pathology associated with CRS with nasal polyps. However, non-type 2 inflammation also plays a role in a number of patients with CRS and includes neutrophilic and polygranulocytic subtypes of the disease. In fact, further evidence suggests that TSLP may play a role in non-type 2 inflammation by providing critical signals for T follicular helper cell differentiation, human B cell proliferation, and mast cell activation. As of early 2025, there are 3 FDA-approved biologic agents for the treatment of adolescents and adults with CRS with nasal polyps that can directly target the type 2 inflammatory processes. Unfortunately, there is still an unmet therapeutic need for biologic agents specifically indicated for non-type 2 inflammatory subtypes of CRS with nasal polyps. However, tezepelumab and itepekimab are fully humanized monoclonal antibodies that target the upstream alarmins TSLP and IL-33 respectively, and are currently being evaluated for their efficacy in treating CRS with nasal polyps. By targeting and inhibiting the alarmins, it is believed that not only can the type 2 inflammatory cascade be hindered, but also non-type 2 inflammation.
Okay, so another audience response question. Which of the following is an epithelial-derived cytokine or alarmin? I'll give you a hint, it did pop up in the video. Number 1, IL-4, number 2, IL-13, number 3, TSLP, and number 4, IL-10. Okay, great. So I think the video did a good job of portraying that. So TSLP is going to be that epithelial-derived alarmin along with IL-33 and IL-25. So kind of thinking about, again, that phenotypic expression of inflammation. The inflammation is happening, and then what ends up occurring in the patient is the vasodilation, edema, mucus hypersecretion, and then again, if you're talking about the lower airway, the airway hyperresponsiveness. And at the end of the day, the patient comes in with loss of smell, nasal congestion, rhinorrhea, and then the nasal polyp formation that you saw in the animation. And then when we think about, again, the upper and lower airway, we like to think about them as 2 parts of one unified airway. So this unified airway model has been around for a very long time, and the idea is that the pathophysiologic events that are occurring in the upper and lower airway are similar. Not 100% the same, but similar. And you can see similar provocations. So allergens, irritants, pollutants can trigger both the upper and lower airway. And in this picture here, you can see kind of the artificial cutoff is going to be the glottis, but the upper airway is going to cause allergic rhinitis, CRS with and without nasal polyps, non-allergic rhinitis, mixed rhinitis, and then lower airway is going to have asthma and eosinophilic COPD. And then right in the middle there, you see aspirin-exacerbated respiratory disease, or NSAID ERD, that is sort of your quintessential unified airway because you have the eosinophilic asthma and the chronic rhinosinusitis with nasal polyposis. And then thinking about, again, the upper and lower airway, we know that there's a lot of similarities in terms of that epithelium. So what was nicely shown in that animation is the ciliated epithelium that is very similar. You saw it in the upper airway, but also in the lower airway, and the goblet cells that produce mucus, which is a very important part of both the upper airway and lower airway inflammatory conditions, as well as the cells. So if you've seen an animation in asthma, especially type 2 asthma, you might have seen something very similar to what was just shown for CRS with nasal polyps, and that's because a lot of the cells are very similar. The Th2 cell, the ILC2 cell, dendritic cell, mast cell, eosinophil, and then thinking about type 1 inflammation, again, the innate, the macrophage and NK cell, but then the Th1 and ILC1 cells. And then just thinking, again, about CRS not as an isolated condition, but about the comorbid diseases that often come with CRS. And so we know that approximately 40% of patients with CRS had comorbid allergic rhinitis previously. I mentioned that AERD and NSAID ERD includes the upper and lower airway, and these tend to be the most serious and treatment-resistant patients, particularly in terms of treating their CRS with nasal polyps, and this is in about 26% of patients. We know that asthma and CRS with nasal polyps occur together in 40 to 70% of patients, which is quite a large number, and these patients tend to have the greater asthma severity. And then with reflux, GERD will coexist in approximately 30% of patients with CRS with nasal polyps. So in the clinic, it's going to be very important to think about all these different comorbidities. If a patient is coming in with one complaint, just kind of taking a step back and asking about the others, and then seeing, does this kind of put them at a higher risk of progressing or of having difficulty after surgery. And so I alluded to this, but compared to patients with only upper or only lower airway disease, those that have both upper and lower airway disease have higher rates of recurrence of nasal polyps after surgery, higher rates of corticosteroid dependence, and we'll talk a little bit about what the implications of that are, more difficult to treat asthma and CRS symptoms, and worse outcomes overall. So just a faculty discussion question for my peers up here. In your clinical practice, so what differences in CRS with nasal polyp symptom severity do you notice in patients with or without comorbid asthma? And so maybe I can start with you, Dr. Ab.
Yeah, sure. So, this is something that I think in allergy practice we're very commonly seeing. And managing both asthma and thinking about how to manage and kind of work with our otolaryngology colleagues to manage chronic rhinosinusitis with nasal polyps. And we do see that in patients who have asthma and chronic rhinosinusitis with nasal polyps together, when they're actually both the asthma and chronic rhinosinusitis are poorly controlled, they're certainly in patients with poorly controlled chronic rhinosinusitis, their asthma severity tends to be worse, and they track together. And it's useful to think about managing them using similar tools. And oftentimes we'll see, in patients with chronic rhinosinusitis with nasal polyps, once you treat the polyps, their asthma will often improve as well, and they'll be less likely to exacerbate. And certainly see this in patients with aspirin-exacerbated respiratory disease or AERD, as you mentioned previously.
And Joe, in the clinic, do you see that this, in terms of surgery, do you see that these are the patients that tend to do worse, or is there not as much of a difference?
Yeah, no, definitely. I mean, the patients with nasal polyps, and they also have comorbid asthma, I will often tell them that, you're more likely to have the polyps come back, and so that even if we do the surgery, it may not be enough, and we'll have to find some good post-operative medical treatment afterwards to try to prevent the polyps from coming back. The good thing is if we can get the polyps better, we'll get the asthma better, and some of the treatments that we use for nasal polyp can also be beneficial for for the asthma. One thing I do notice also, the difference between patients with nasal polyp and those with asthma, actually people who usually have more severe nasal polyp tend to be actually a little bit higher among men. But if you have asthma, it tends to be a little bit higher among women.
That's an interesting observation. I like setting up that expectation ahead of time because I think people often think the surgery is kind of one and done, and it's nice to kind of set them up for what might actually happen. So with that introduction, I'm going to pass it along to Katie here, who's going to discuss our next section.
Great, thank you so much. So I'm going to talk about the consequences and burdens of chronic rhinosinusitis with nasal polyps, so how this really is impacting our patients. So chronic rhinosinusitis with nasal polyps can really cause severe symptom burden that significantly impacts people's quality of life. The polyp tissue itself can obstruct the sinuses and nasal passages, make patients feel blocked, like they can't get air in and out. And this, can also have significant impacts in terms of effects on sleep and just general well-being. We often talk to our patients and say, you feel like you have maybe the worst cold of your life, but all the time, and this is bad. It can also cause impairments in sense of smell, which again is a big deal to people. It makes it so that they can't smell danger signals, things like a gas leak or a fire, for example. And many patients have really uncontrolled symptoms that can be really unremitting, and they can certainly exacerbate at times. But they feel these symptoms almost every day. And they get exposure to frequent courses, often of oral corticosteroids, which can have detrimental side effects as well. Things that in the short term they experience, like insomnia, weight gain, things that are disruptive to them, and also long-term side effects. And we know that this places a significant burden in terms of cost and healthcare utilization. So these patients will have frequent urgent care visits. Certainly the surgical care is burdensome and needing to potentially have sinus surgeries, potentially revision sinus surgeries, has associated costs and also detriment in quality of life as well. So really impactful in terms of how patients feel on a day-to-day basis and the healthcare utilization that they need to seek. So in terms of targeting underlying mechanisms of disease, there's now 3 FDA-approved biologics for asthma and chronic rhinosinusitis with nasal polyps. So, what's available right now, dupilumab, which targets IL-4 receptor alpha and inhibits signaling of both IL-4 and IL-13, is approved for moderate to severe asthma or with the eosinophilic phenotype or oral corticosteroid dependent asthma in 6 years and older, and also inadequately controlled chronic rhinosinusitis with nasal polyps in both adolescents and adults. Mepolizumab, which targets interleukin-5, is approved for severe asthma with the eosinophilic phenotype, again, age 6 and up, and for adults who have chronic rhinosinusitis with nasal polyps. And omalizumab, which targets IgE, is approved for moderate to severe persistent asthma, inadequately controlled with inhaled corticosteroid with a skin test or in vitro test showing reactivity to an allergen in ages 6 and up. And then again, adults with inadequately controlled chronic rhinosinusitis with nasal polyps who are on an intranasal corticosteroid. So we now have these tools available. And looking at this somewhat confusing slide, but I think interesting and kind of good to know about slide, we see that these currently available therapeutic targets target really important places in the type 2 airway pathophysiology that we briefly reviewed in the video reviewed. So mepolizumab targets IL-5, and we know that has impacts in terms of eosinophil migration, differentiation, and leading to trafficking of eosinophils into the diseased respiratory tissue. Dupilumab, by inhibiting IL-4 and IL-13, can have impacts on B cell class switching to IgE. It has direct impacts on mast cells. IL-13 can lead to macrophage polarization, fibrin deposition, and IgE specifically, inhibited by omalizumab, has known impacts on mast cell and basophil activation. And so, these are pathways that were currently available to target. That said, there's, I think, so much more that we can do for patients, but there are certainly still some unmet needs. Right now, there is no FDA-approved biologic that's specifically targeting non-type 2 chronic rhinosinusitis. And, despite our current therapies, there are still patients who have allergic rhinitis or chronic rhinosinusitis who still experience uncontrolled symptoms. And again, it's not just the nasal blockage and anosmia or impairment in spell. It's really well established that chronic rhinosinusitis can lead to significant impacts in mood. So, there's really like emotional symptoms, irritability, depression associated with it, decreased cognition. So patients feel like they can't concentrate. They might describe it as a brain fog type symptom. And, impairment in function. People feel like they're less productive at work or having difficulty concentrating at school. And we see that, really there's a large proportion of patients with asthma who have uncontrolled disease. Again, they're getting high levels of stress related to it, high medical utilization. We certainly know in our patients who have bad comorbid asthma and uncontrolled chronic rhinosinusitis with nasal polyps together, their asthma can be more severe. It can be quite a severe spectrum. So they're at increased risk of things like death, which we don't see very often from asthma anymore, but it is something to consider in your really severe asthmatics. So another question for the group, which, and maybe I'll start with Joe, is what do you think the greatest unmet need is that you encounter with current biologic therapies for chronic rhinosinusitis with nasal polyps?
So I would say the addition of a new therapeutic option, the biologic for nasal polyp, has actually been a great addition. But despite that, there are still some unmet needs. meaning that not, the biologic, for nasal polyp isn't all 100%. So even with the biologics that we have, they're very good, but it's not effective in every nasal polyp patient. So that's one thing that I've seen. But I'll leave it up to Flavia to answer.
Yeah, and I mean, I agree with that. I think also you mentioned in your slide, the non-type 2 patients don't really have an option. And I think, knowing which one to choose is often hard. And we're going to talk about biomarkers in a little bit, but I think until we have better biomarkers to help us make the right choice the first time, or know that somebody's not going to benefit and we need to kind of take a different path, I think those are some unmet needs.
Yeah, I was thinking the same thing as you, which is, biomarkers that guide treatment in general. So, is surgery the right thing for the patients versus are there specific biologic agents that may be more or less efficacious for a particular patient? So I think kind of establishing markers that can move us toward personalized treatment in these patients is something that we're unable to do, or we have really limited tools that we can use right now to direct our current therapies. So that would be, I think, very helpful. Great. So there's more coming, which I think is, maybe going to start to address some of these unmet needs in our patients with chronic rhinosinusitis. So there are a number of ongoing phase 3 clinical trials for chronic rhinosinusitis with nasal polyps. Benralizumab, which is available for asthma, targets IL-5 receptor alpha. There is a phase 3 clinical trial ongoing right now called Orchid. CM310, which is a IL-4 receptor alpha targeting monoclonal antibody, is under investigation. Depemokimab, which targets IL-5, it's an ultra long-acting antibody with less frequent dosing, is under investigation. Lebrikizumab, anti-IL-13, is being studied, and then tezepelumab, which targets TSLP, as we talked about earlier. This is a little bit different in that it's an epithelial cytokine, is under investigation. I think, we're soon to hear more about some of these studies in the study Waypoint. So we will learn more about this. But to look back at where these investigational agents are targeting, there is some overlap with what we've seen already, although I think some potential differences in some of the investigational drugs. We see that IL-5, again, is targeted by depemokimab, and using benralizumab to target the IL-5 receptor targets a similar pathway. There's the new anti-IL-4 receptor and anti-IL-13, which will target some of the same pathways that dupilumab targets. But then looking at anti-TSLP, which is further upstream here, again, epithelial cytokine can have a variety of downstream impacts that we had reviewed in the video earlier. So I think that this is really going to be interesting to see how we can use these drugs to really optimize care and kind of fill in some of these unmet needs for patients who aren't having adequate response to current treatments and are looking for something new. So I think that this will be certainly an exciting time to really learn more about how we can best care for our patients with chronic rhinosinusitis with nasal polyps. So we have another audience response, which is which of the following cytokines represents the therapeutic target you are most excited about for patients with chronic rhinosinusitis with nasal polyps? Okay. So it looks like there's no wrong answer for this one, but it looks like people are most excited about TSLP. So with that, I will turn it over to Joe, who I think will tell us a lot more about addressing challenges.
Thanks, Katie. And so let's talk about chronic sinusitis with nasal polyp. when you're treating patients with chronic sinusitis with nasal polyp, one of the things that you want to do is be able to have some type of measure. Like if someone says, like, I feel miserable today, you give them a treatment, they feel better. Well, they say they feel better, but how much better are they really feeling? And so one of the things that we could do are have, different outcomes measures. So like for asthma, you have ACT, you have ACQ. For chronic sinusitis, you have SNOT-22, and the SNOT-22 is the one that's commonly used for these clinical studies. But another one that I think is very nice is PGSS or VAS score. And actually, we just published a paper looking at the VAS score or the PGSS. And what it showed is that score can be helpful in predicting what treatment options the patient wants, which is actually very nice. There are other ways to kind of decide if the nasal polyp is going to be difficult to treat, and you could look at different biomarkers. You could look at CT scan. CT scan can also be predictive of how severe the inflammations are. You can also detect whether or not they have asthma, and you could do pulmonary function tests, FeNO, or sometimes I'll even order occasionally methylcholine on challenge tests. Yes, an ENT doctor can still order that. And so Flavia, what patient-reported outcome measures or objective measures do you routinely use in your patients for chronic sinusitis with nasal polyps?
Yeah, so like you said, the SNOT-22 I think is the most commonly used, and that's what we're still using for now. But I'll read that paper of yours. And then in terms of asthma, we use the ACT score. We like the AirQ as well. It just hasn't become mainstream yet, but that one looks at risk and not just impairment. So whereas the ACT looks more at control. And then objective outcomes, again, we're going to talk more about biomarkers, but it's tough to find that ideal biomarker that tells us when there's a disease state and then when it's better and helps kind of direct to therapy. So right now I'm mostly using kind of objective outcomes like, as you mentioned, sinus CT scan, definitely relying on my ENT colleagues for the nasal polyp score and that endoscopy information.
Kitty, anything more to add?
Yeah, so sometimes we do SNOT-22 and ACT and similar patient-reported outcome measures. In terms of objective measures, in some patients, especially patients that we're following with aspirin-exacerbated respiratory disease and looking for improvements in sense of smell, we'll do some objective smell measurements. So we'll do an upset score, which is done in a lot of clinical trials. I'm sure you're using it a lot. But it's a scratch and sniff test, which can be helpful, but it's super time consuming. So, patients need to come in early. It takes like up to 20 minutes to do it. So they need to come into clinic early before, we're gonna see them and have sufficient time to do it. So that really can limit it. And also they can sometimes, cost can limit the use of that as well, but I do find it to be helpful.
Okay, great. And so, what, as you heard what Flavia said is, one of the unmet needs is, how do you know of all the biologics that we have, that which biologic will work? So if you have a lab, where we actually measured IL-4, IL-5, 13, interferon gamma, and IL-17, you can kind of predict which biologics you can use. But right now, they're not commercially available, and unless you have a lab to do that, it's difficult. And then you can also kind of measure these cytokines usually through tissue, the blood, nasal secretions. And basically the reason why we're looking for these biomarkers is try to increase the efficacy of the treatment options that we have, and also to kind of predict the prognosis of how the patient is going to do. So we do have currently some things that are currently commercially available, some things that you do have to measure through the lab. So currently we're looking at nasal nitric oxide. And so, that is interesting, but, it's difficult to decide how to use that. You can measure specific IG and total IG, which are commercially available, and you can measure neutrophils. And urine LTE4 is actually available as well commercially. And so these are things that we can use to kind of predict how the patients are going to respond in the future. But what we do have, and I think it's a good time to be able to treat our patients with nasal polyp because we have so many new treatment options. In the past, we were really relegated to using topical steroids, nasal rinses, or oral steroids. But now we have different ways of delivering topical steroids like EDS fluticasone. We have steroid stents that you could put into the sinus cavities. Now we have the list of different biologics that you saw, the 3 of them, and there's a lot more coming out. And actually, our understanding of how to do surgery for a specific type of sinusitis has gotten better. So just like the medical treatment for sinusitis varies depending on the type of sinusitis you have, same thing with surgery. So not all sinus surgery is the same, and how we do the sinus surgery to increase efficacy has also improved as well. And so just going into a little bit more details, different options, I think nasal steroid spray and irrigations, the evidence isn't high, but it's low risk, and they do find patients found to be helpful. Intracortical steroids, mebendazole specifically, is approved for nasal polyp, but none of the other ones are. And that, in fact, intranasal cortical steroid spray, when it was evaluated for chronic sinusitis, actually didn't work. But even though it didn't really work, it has become standard of care, and people do use that often. Antibiotics, there really isn't a lot of support for it, but there is a use for long-term macrolides for non-allergic or low IgE sinusitis. So the non-type 2 CRS, I think, is helpful. Oral corticosteroids, of course, is very helpful in our patients with nasal polyp. But the problem with oral corticosteroids is that if you have cumulative dosing of oral corticosteroids, it causes a lot of issues, right? And so that's one of the things that we want to try to decrease the use of. So what we've been doing is, we know corticosteroids work great for people with nasal polyp, but the thing is, we're trying to look for alternatives. And so we've been looking at, I think Biologic really has been that great addition to substitute the oral steroid use. And so I'd like to ask a question to the audience. What is the most common first-line treatment in patients with chronic sinusitis with nasal polyp? 1, nasal saline spray. 2, nasal saline irrigation. 3, intranasal corticosteroids. Or 4, macrolide antibiotics. Music? Thank you. Okay, actually, so intranasal corticosteroids, and so actually very interesting. All right. So, what's kind of interesting is, when Biologic got introduced, a lot of people were saying, is it Biologic treatment? If someone has nasal polyp and severe nasal polyp, a lot of the initial discussion were, should we give them Biologic or should we do surgery? But I think our understanding of Biologic and surgery has gotten better. And so now we're starting to understand it isn't one versus the other. It's more likely, when do we choose one, or when should we choose the other? Or is it better to maybe do a combination of the two? And so there are a lot of studies that are going on looking at the combination of surgery with Biologic. And actually, the initial studies are showing that if you give them Biologic before surgery, actually the outcome after the surgery tends to be a little bit better. And so, what are the different factors that we kind of consider in, choosing if we have a patient with severe nasal polyps, how do we decide to do surgery versus Biologic? And there are certain things that I think we can kind of go through. So one is, I think most experts would say, if you have a bad nasal polyp, you should probably do a good sinus surgery. So if you do a really good sinus surgery where you open up all the sinus cavities, make the openings very large, that's usually the first line. if the polyps come back, and as you heard earlier, usually these are patients with asthma, the ARD patients. If these polyps start coming back, instead of doing sinus surgery again, maybe consider maybe a biologic option. And especially in those with asthma, I think are really good candidates for a biologic option. And I think this is a really nice slide. This is a paper published in 2017. It's actually one of the most referenced paper I like to talk to physicians about, because this slide kind of tells you that chronic sinus with nasal polyp, once you have the diagnosis, you have it for life. And so a lot of people think that, a lot of patients come in thinking that if they have sinus surgery, get rid of all their nasal polyp, which we can do with sinus surgery, they think that their polyps are cured, but that's not true. And so what I tell them is that, with sinus surgery, it is helpful. Now, I do want to say that if you have nasal polyp in general, and you do undergo sinus surgery is very effective. And actually, the recurrent need for sinus surgery in all comers of nasal polyp is not for 12 years. So if someone had nasal polyp surgery and you do sinus surgery, for 12 years, they probably don't need another surgery. But that's not true for every nasal polyp patient. So if you have nasal polyp and you have ARD, actually within 3 years, you need to have sinus surgery again. And so these are things that we need to consider when we're talking to our patients. Now, this is one of the questions that we ask the audience and all the participants. So if you were treating patients with nasal polyp, we asked the group, what percentage of your nasal polyp have polyps come back after surgery? And I would say, majority of the people are saying, yes, there is certain amount of nasal polyps that come back. I would say for me, it was none, because I do excellent sinus surgery. That was a joke. No, my numbers are still pretty high as well, just like Adam DeCon paper showed. Now, one of the things that we look at is, how do you predict, if the polyps are going to come back? And so, that's, as you heard earlier, if you have comorbid asthma, you have ARD, I tell them your chance of polyps are coming very high. And and if the symptoms are bad, the polyps are going to come back very quickly. If you have a bad CT scan or nasal polyp scores are really high, the chance of the polyps coming back are pretty high. So those are the things that I often talk about when we talk to patients with nasal polyp. Now, how do you distill all that, right? So, there is this group called Euphoria and EPOS, and this is based more in Europe. And what they did was, or actually what we did was, we said, how do we make it easy for clinicians to decide who should get a biologic? And so I think, the simple answer is uncontrolled severe nasal polyp. These are the patients who should get biologic. But if we were to kind of break it down into a little bit easier criteria, we said, it would be nice to be able to show that the patient has some type of type 2 inflammation. And so the way we define type 2 inflammation is what we see there. We said that, we don't want to keep giving systemic steroids. We think that 2 systemic steroids in a year is way too much. So if there are repeated use of systemic steroids, those are patients that are a good candidate. Certainly people who lost their sense of smell or their quality of life is significantly burdened. These are the patients that we think should get biologic, and especially the comorbid asthma, I think, is a very good predictor. Actually, patients with nasal polyp, actually allergic rhinitis is actually more common, but doesn't seem to influence the prognosis of nasal polyp as much as asthma. And that's why asthma is such an important question to ask when you see patients with nasal polyps. After you start them on biologic, how do you know it's effective? And so we wanted to evaluate several things. So is the nasal polyp score getting smaller? Is the patient's symptoms improving? Is their smell getting better? So if they're getting better, and we said, how much of the different criteria, and we broke it into good response, moderate response, or poor response. One of the common questions that I get is, if you start them on a biologic, how long do you wait before you decide, well, the biologic is not working? Because that's actually a very common question I get from my patients when we start them on biologic. In the past, when we initially wrote this paper, we said it was 4 months, and it was influenced by multiple factors. So we initially said 4 months. But I think what we're starting to realize is 6 months is a better number because we see patients continue to improve, and then at 6 months it starts leveling off. It still continues to improve, but a lot of the biologics level off. So we said maybe 6 months is a better number. So at 6 months, when I see them back again, I'll ask them how they're doing. I'll look at these different criteria. If they're not getting better, I will either switch them to a different biologic or talk about other treatment options like the steroid stent or even doing revision sinus surgery. And if they feel like they had a moderate response or maybe not as good of a response as you hope, you can continue them for another 6 months and reassess them again. Now, so you heard about the biologics that are currently approved. What are some new biologics that are now currently being evaluated? So you guys probably heard of tezepelumab. That is a biologic that targets TSLP. And actually, tezepelumab was studied for asthma. And that phase 3 study was called Navigator. Within Navigator, as you would expect, there were people with asthma and nasal polyp. So we did a subgroup analysis, measured SNOT-22, and when we gave the patients with asthma and nasal polyp and measured the SNOT-22 with the intervention of tezepelumab, they got better. So because of that, we said, okay, well, let's do a phase 3 study for nasal polyps. And so that's the Waypoint study. And you probably heard the press release that tezepelumab has met its primary endpoint, so it improved nasal polyp score and nasal congestion. And if you really want to hear the presentation, I am presenting it on tomorrow afternoon at the late-breaking abstract. So definitely come and listen to that. Pretty exciting data. And that this study actually is accepted for publication, and it will be released at the same time. Benralizumab, as you heard, were 2 phase 3 studies, Austro and Orchid. So initially when they did the Austro study, the regulatory agency said, we would like to actually have a little bit more data. And in fact, we were already starting the Orchid study anyways. And actually, after we finished the Austro and Orchid data, it didn't meet its primary endpoint for Orchid. So benralizumab, unfortunately, is not going to get, there isn't going to be an application for benralizumab for nasal polyp. We are working on the publication, and hopefully we'll have the publication for Orchid pretty soon. As you heard, there was an IL-4 receptor, and what was interesting is, how it ended in, most of the biologics that we have usually ended in MAB, monoclonal antibody, but for this IL-4, it ended in ART. And so you're going to find out that a lot of the new biologics are going to end with different suffixes. And so for this one, the phase 2 study was CROWN, and the phase 3 study is CROWN 2. And this is specific to China. So this was studied specifically in China. This paper is now submitted for review, and we'll see the data. And then the other one is depemokimab, and so that is an anti-IL-5. And so the study is called Anchor 1 and Anchor 2. And if you look at the press release, that was also met primary endpoint. And again, that is also being, I'm also presenting that data tomorrow afternoon. So if you want to come to the late-breaking abstract and see this exciting data, I'll be presenting that as well. So it's very exciting that we have so many different treatment options available for our patients with nasal polyp. Now, one of the things that we see with chronic diseases is some of these terms that you hear, control, remission, and possibly, even cure. And I think nasal polyp is no different. We see this with rheumatoid arthritis. We're starting to see it with asthma. And I think it's very relevant that we should be talking about these terms for nasal polyp. And so the way we defined it is if the patient's symptoms are controlled for 4 weeks, it's controlled. If the nasal endoscopy and symptoms are well controlled for 12 months, that is remission. And in remission, one of the questions that came up is there remission while they're on medicine, or do they all have to be off medicine? And so when we wrote this paper, we decided that even with medicine, it could be called remission as long as the medicine does not include steroids, which we're see. And so, Katie, so let's ask this question. Is sustained remission, by definition, achievable and realistic for our patients with nasal polyp?
Yeah, this is a really, I think, interesting question. I think that it is achievable, and we do see this in some patients who are really super responders to currently available drugs, where they will stop their other medications, they'll stop their intranasal steroids and really have no symptoms at all. We see that their sense of smell returns, and I'm often told by my otolaryngology colleagues that the mucosa has normalized. So that is the case. You know, there are also patients where they are so much better and they're no longer needing oral corticosteroids, they no longer really need surgery. You know, there might be times where, you know, they do not have the most keen sense of smell here or there, but in general, they're doing much better. So, you know, I don't necessarily know with the tools we have available now, it may not be realistic for everybody, but there are a lot of patients who do superbly well, even if they have some mild symptoms.
Flavia, anything to add?
Yeah, I'd agree with that. I think if you had asked, you know, 5, 10 years ago, we'd say no. But now I think with the biologics we've got, and then with the ones on the horizon, absolutely. I also think, you know, you were alluding kind of to the low disease activity, which is the term that has been used in some of these other chronic disease, where it's like, you know, it's pretty darn good. And so that could be kind of the goal for those who can't achieve full remission, but still a lofty goal. So.
Okay, great. So Flavia, so how does the presence of atopic comorbidities such as asthma affect the likelihood of achieving sustained remission?
Yeah, so I think this goes back to the unified airway, right? We've been alluding the whole time, the patients that have that upper airway, lower airway, asthma, AERD in particular, are going to be the ones that are hardest to treat. They also tend to be the type 2 patients, and so we do have biologics for those patients. So I think it's kind of like a tug and pull there. And then you mentioned allergic rhinitis, you know, not as much of an effect. So I think you just have to go in kind of understanding that they have those comorbidities and that they may impact the trajectory.
Yeah. Anything to add?
Yeah, no, I agree with everything you say. I think thinking of asthma as really a surrogate marker for type 2 inflammation is helpful in these patients. And often the folks with polyps and comorbid asthma do really well on biologics. So similar experience. I think this is
fantastic,
exciting.
And so we know that, you know, even though the biologic has been a great addition to the way we treat our recalcitrant nasal polyp patients, you know, these are patients who are very difficult to treat. There are some barriers in trying to get the biologics for our patients. Sometimes it's the high cost, not necessarily to the patient, but the high cost to the healthcare system, difficulty in trying to get the insurance to approve it, because if the insurance doesn't approve it, most patients are not able to afford the biologic. There are some potential side effects, and, you know, in the phase 3 study, I think in general, biologics are very safe. But, and in the phase 3 study, there wasn't any issues that we saw. But as we've been using these biologics more and more, we're starting to see some nuances and some side effects, not very common, but we're starting to see some of these things. And there are some people who are allergic to needles. And so, and, you know, when I specifically asked them, you know, I've got this new drug that's going to be great. And then the first thing when they hear is a sub-Q injection, I have patients who just said, no, I just don't want it. And so, Katie, so how do you overcome these barriers in using biologic for nasal polyps?
Yeah, so, you know, I think a huge piece is setting expectations with patients. So introducing this concept early and really providing reassurance. We'll often have patients come to us for their initial injections and do a lot of teaching and hand-holding through this. And certainly for our younger patients, like teenagers with polyps, will, or asthma for that matter, you know, we'll do a lot of expectation setting about this is what you might expect in terms of discomfort for this. Because I think if they know going into it, that can really help them buy into it a lot more rather than surprising them with a, you know, painful injection. So that is helpful. You know, I think that in terms of cost, that can be challenging. for certain scenarios and certain patients, and working closely with them. We have actually at my institution a specialty pharmacy that provides us a lot of assistance with that, so it can be really helpful. And I think we've made a lot of headwind utilizing them as a good resource in terms of being able to get patients the drug that they should be on.
Oh, yeah, and I'd agree. I think we have a utilization management team, and so they know kind of the ins and outs, and that's really helpful. But if you don't have that, I think the companies are also really helpful. They have knowledge about how to kind of get around things, or what programs might be out there that can help the patient, making sure that all the patients know about the assistance programs, and then documenting really well, because I think a lot of times the first instinct is to refuse, and it's just because like one checkbox isn't met. And so really documenting everything they've tried, and just how severe the disease is, how many surgeries they've had, nasal polyp score some of the insurances require. So documenting that all up front will save your team the time on the peer-to-peers and the appeals and that sort of thing.
Okay, fantastic. So let's go back to the future. So, Flavia, so do you think that the future FDA approval of any or all the biologic therapies will lead to the change in our algorithm on how we treat patients with nasal polyps?
Yeah, so I think Katie earlier kind of alluded to a lot of the newer therapies are targeting some of the same part of the inflammatory cascade. And so there it's thinking about, it might be more subtle differences or big differences like the depemokimab, which is twice a year, right? So for a needle-phobic patient, they might be more likely to sign up for something that's twice a year than something that's every month or every 2 weeks. So I think things like that can be impactful. But obviously, targeting a different part of the inflammatory pathway, I think probably would make the biggest difference. So the anti-TSLP, which seems like the closest of the epithelial alarmins, but then even IL-33, I think, would potentially lead us to broaden beyond the type 2 patient to the non-type 2 patient and be able to treat more aggressively there.
Yeah, no, I would agree. We'll see if having some of these epithelial cytokines become available, if we'll have different cutoffs in terms of, looked at the current euphoria guidelines where it's, IG of 100 and eosinophil count of 150, maybe that will go away or be different in the future for specific biologics. So I think that would be, something to look forward to.
Yeah, and and one of the things that, when we see patients with nasal polyp, you ask them, what mode of treatments do you like? So is it pills, and pills is definitely number one. Number two is sprays. They would rather do sprays than injections. And then, there was actually a survey in, when they were asking patients, when does the oral medication get substituted by injection? And that's when they went to Q6-month dosing. And that's when patients started switching over and saying, I would rather get the Q6-month dosing rather than oral pills. So like you said, depemokimab is coming out, is Q26 weeks, so we'll see. In the next few years, Katie, in the next few years, do you think we will have biomarker assays to help guide the therapy?
Yeah, this is a great question. I hope this is something that's coming. I think we were talking earlier, the next few years might be ambitious, but I think that there are a lot of new tools that we're utilizing. And I think one thing that we're learning is that actually looking more closely at the site of inflammation rather than like for a marker in something like peripheral blood. So looking at nasal mucus or actually like nasal polyp biopsies might be a better place to look for biomarkers that are going to be more sensitive and specific. And really help guide therapy. In chronic rhinosinusitis with nasal polyps, obviously it'd be easy for our patients to all just go get a blood draw and have this answer, but that might not be, at least to start, the best place to look. So I think being creative about where we're looking will be important in the future.
Yep, yeah, absolutely. Because it'd be nice to be able to get some mucus samples and say, hey, you're very high in IL-5, so let's do that, or you're high in TSLP, let's do that, or IL-4. IL-4 is a little bit harder to detect. IL-13 is probably a little bit better, easier to detect.
I think that with CRS, with nasal polyps, it's so much easier than with asthma in the sense that we can't, you're doing an endoscopy every time you see the patient, right? Mm-hmm. So you're in there, whereas we're not doing a bronchoscopy every time we see these patients with asthma. So I think the nose is a little bit more accessible.
Yeah. No, absolutely. And we can not only do nasal endoscopy, but we can get biopsies of the polyp in the office, even without anesthesia, because there's no nerves on the polyp, and there's not a lot of blood vessels there anyway, so you can biopsy it, it doesn't hurt the patient, and they don't even bleed very much.
And in your experience in the operating room, do you actually send the samples for eosinophils or for IL-5 or anything like that routinely?
Yeah. So I did. So I did when I did a lot more of the bench research. I got the polyp specimen, gave it to my research assistant. She liked working late at night, so she did all the single cell thing and worked till like 2 or 3 at night, and then woke up at noon. And so, yeah, we used to, but now we kind of try to rely on our pathologists, and it varies. Like, we have several pathologists who are very good, who will actually measure the tissue eosinophils. Some of the pathologists will just say, oh, there is eosinophils. So, so it kind of varies a little bit. Did I ask this question? Do you think, Katie, do you think we will treat patients with type 2 and non-type 2 CRS with nasal polyp based on the different treatment algorithms?
I think we will, yes. I think we will probably be using different treatment algorithms for this going forward. I think we discussed earlier some important clinical differences that we see in patients with type 2 and non-type 2 disease. Specifically really important for us would be comorbid asthma. So, that automatically I think is a big change. And as I think we can more easily identify patients with type 2 to non-type 2 disease, as we have really good, reliable biomarkers up front, we may be considering different treatment options downstream. We talked about macrolide antibiotics, and if we have available biologics that work on non-type 2 disease, that would clearly be kind of a different pathway as well. So, we need better diagnostics and therapeutics for the non-type 2 patients together to do this.
Great. Anything to add?
Yep, no, and I think sometimes they come together, right? You get the better therapeutic and then kind of back into the better diagnostic and vice versa. So I think the future is exciting.
Okay. Yeah, definitely. And I think hopefully what you were able to take away from the presentation tonight is that, the upper airway and the lower airway, they do coexist in patients, and one disease does affect the other. I think that's important to know. I think that the new introduction of biologics are effective and safe for our patients with nasal polyp. And as you saw here tonight, this is a multidisciplinary panel, and I think that's how you provide the best patients. So back at home, we have a severe asthma consortium where I work with allergists, a pulmonologist, and they work with me, and together we kind of treat these very difficult to treat patients with nasal polyp. So with that said, remember those questions you answered in the beginning? Now we're going to see, how you do. Have we done a good job and explained the information to you? So the first question is, which of the following plays a key role in orchestrating upstream activation of both type 2 high and type 2 low or non-type 2 inflammation pathways in the upper and lower chronic inflammatory airway disease? 1, TSLP, 2, interferon gamma, 3, IL-17, and 4, IgE. And we're going to show you what you guys answered in the beginning and then what you're going to do now. So, all right, go ahead. Let's play the music. So, Flavia, what do you think?
I think
Do we have our...
there's the before and after. Yeah, I mean, we were already pretty good in the beginning, so, but we got up to 97%, so you can't do too much better than that. Okay. Good work.
Fantastic. You guys are rock stars. All right, let's go to the next question. And so post-op, question number 2. Which of the following factors would support the recommendation of starting a biologic therapy in patients with recurrent nasal polyp? 1, low FeNO, 2, history of balloon sinuplasty, 3, nasal polyp recurrence 1 year after sinus surgery, or 4, low blood eosinophils. All right. So wait for it. Okay. Katie, what do you think?
Yeah, so everyone did, I think, very well in the pre-test actually and post-test. Yes, we would consider Biologic in someone who's had pretty rapid nasal polyp recurrence after endoscopic sinus surgery. Right now, for nasal polyps, low FeNO wouldn't be particularly helpful. Low blood eosinophils doesn't meet the type 2 criteria, and history of balloon sinuplasty isn't, really, and you can actually speak more about this, but isn't really an adequate surgical intervention in most cases.
Yeah, and and even though balloon sinuplasty is meant to be a minimally invasive procedure for sinusitis, it's not really indicated for nasal polyps. So absolutely right. All right, great. You guys are awesome. Question number 3, which of the following phase 3 clinical trials is evaluating the role of biologic that targets TSLP in the treatment of patients with chronic sinusitis with nasal polyp? 1, Anchor, 2, Orchid, 3, Waypoint, or 4, Contrast NP? I think this is actually a pretty tricky one, so we'll see if you guys get, well, not tricky, I think it's difficult, unless you kind of see these data on a regular basis. Okay. Hey, Flavia?
Yep, so this was the preview to tomorrow, right? The Waypoint study that Joe is going to present tomorrow. But like he said, I mean, this is probably, the name of the study is the least important thing to take home, right? It's that anti-TSLP has real promise. And so you all increased your knowledge there. The name is Waypoint.
Fantastic. Question 4. So Nicole is a 35-year-old woman with a history of severe and uncontrolled CRS with nasal polyp, has undergone 2 sinus surgery. She is currently using intranasal corticosteroid, oral steroids, 7.5 milligrams a day, still has significant fatigue, nasal pressure, loss of smell, and her quality of life is impaired. So which of the following would you recommend for Nicole at this time? A, add on biologic therapy, B, add on macrolide antibiotic, C, repeat sinus surgery, and 4, increase the dose of oral steroids.
Yeah, sure. So poor Nicole is miserable. I think at the beginning and end, most people selected biologic therapy, which, given her really uncontrolled disease, prior history of steroids, repeat surgery, and need for prednisone, I think biologic is indicated here, which you all agree with.
Yeah, and I think 5% of the people in the audience must be ENT doctors who voted for sinus surgery.
Yeah.
All right, question 5. Approximately how often will you now recommend biologic therapy in patients with uncontrolled CRS with nasal polyp? 1, never. 2, 25% of the time. 3, 50% of the time. 4, 75% of the time. 5, 100% of the time. Or 6, I do not manage patients with CRS with nasal polyp. Okay. So, Flavia, what do you think?
Yeah, so these numbers are, this question's a little bit different, but I think in general it was moving towards more people now recommending biologic therapy than at the start. I think chronic rhinosinusitis with nasal polyp is a little bit behind asthma in that the biologics haven't been around quite as long. And so I think part of, the first step is always getting the word out there. Once you start prescribing it, you'll see these patients get so much better and really just the quality of life increases so much that then you'll just keep prescribing because that positive feedback is hard to ignore.
Yeah, so what I see is number 6. I do not manage patients with nasal polyp. So actually, after the lecture, 6% of the people felt more comfortable treating nasal polyps. So good for you guys. Awesome. All right, and then number 6, approximately how often will you now utilize SNOT-22 questionnaire to determine symptom burden or guide therapeutic decision in patients with CRS with nasal polyp? And I would say not just SNOT-22, but like other patient-reported outcomes measures. So 1, never; 2, 25% of the time; 3, 50% of the time; 4, 75% of the time; 5, 100% of the time; and 6, I do not manage patients with CRS with nasal polyp. All right, Katie, what do you think?
Yeah, so it looks like, didn't change a ton, but maybe have a handful more patients who are going to, a handful more folks out here who are going to be using SNOT-22 scores. So, I do find it to be very helpful and glad we were able to talk about it.
Okay, great. And I think that's it. And I think we got a list of questions from the audience. So,
yeah,
Katie?
So I'm happy to get started. So this is something I think that Flavia had brought up, which would be maybe good to hear what you do. What do you document in a patient's chart to get biologics covered by insurance? So what information do they need?
Yeah, so I usually will mention what therapies they've tried and be specific there. And how many surgeries they've had, what the sinus CT scan shows. Definitely if you've had an ENT actually do an endoscopy, I would document that this is a multidisciplinary approach and we both agree the patient needs the biologic. And then if you have a nasal polyp score, you can include that. There have been a couple of times where I didn't include the score, but then of course the insurance wants it. And I'll look back at the ENT notes and as long as they document well, they can either add an addendum with the nasal polyp score or you can calculate it. So those are the main things I do. I don't know if I'm missing anything. Certainly if they've tried another biologic and they failed that, because a lot of the insurances now are, you have to fail this one before we move on to this one, and it's often very arbitrary, which is 1 versus 2 versus 3. So if they've tried another biologic, even if it was for asthma and their sinuses didn't respond, then I'll include that as well.
Yeah, and sometimes some of the insurance companies want you to see the patient back to also document that they did get better so they can continue on the biologic. So oftentimes the first time I do the biologic, I'll have them come back in 3 months so that I could reassess them at 3 months and document that they actually got better or they didn't get better. Or if they're heading better, then I'll document that as well and see them again in 3 months.
And that's where the SNOT-22 score can be very helpful because, patients may say, oh, I think maybe it's helping, but if the SNOT-22 score is actually moving in that right direction, then that what is perceived as a maybe, now you've got it quantitated, so.
Yeah, that's a good point.
Yeah, I would agree with all those things. And we actually have a templated letter for every, that we generally use for biologics for nasal polyps. We have one for biologics for asthma, and we just follow the same. So we don't forget any of those things because it can be a lot to remember. But it, is just like fill in the blank. We do it, which is very easy and nice and convenient. So this next question, actually, maybe Joe, you can speak to this first. How fast can you taper oral corticosteroids on a biologic?
And so I would say it depends on the patient. And so one of the issues that we see in patients who get biologic, if you wean the steroid too fast, it can cause an exacerbation. And so you want to be able to slowly wean the patients off. And so whether it be for nasal polyp or asthma, you don't want to wean it off too quickly. And so you want to be able to gently wean it off.
Yeah, and I think the other thing is always to mention that we're not using the steroid for energy, right? And so when you come off of steroid, especially if you've been on for a really long time, you're probably going to get tired and you might feel a little achy. And I think setting that expectation with the patient that they may feel that, but they should get past that, and then we'll make the next step, and we'll go as slowly as they need, kind of thing. I think is very helpful because otherwise, they just feel terrible, and it's not that their nasal polyps are back; it's that they have been relying on this exogenous steroid. And then I think patients who have been on for a really long time, once they hit that 5 milligram kind of physiologic dosing, I'll sometimes get endocrinology involved or wean like incredibly slow, maybe 0.5 milligram at a time or maybe 1 milligram every few months and just kind of follow the cue of the patient at that point.
Yeah. So this next question I think is actually really interesting. If approved, which patients with chronic rhinosinusitis with nasal polyps would you potentially use tezepelumab for? So I'm happy to start with this because it's kind of a hard one. But we've been using it now for a while for asthma, and it works, I think, very well in patients with type 2 high asthma. It's actually a great medication for those, as well as patients with type 2 low asthma as well. So thinking about patients with nasal polyps, it may be a good drug for actually all comers with nasal polyps. And we have, I think, a lot more to learn as we're practicing. We'll also learn a lot more, when we're getting a really good look at the data from the phase 3 studies. But I'd love to hear, Joe, what you think, or you can take a lot.
I'll say, you got to come to my talk tomorrow to hear that answer. So I'm sorry.
Yeah, no, I would agree though. I think when it first came out for asthma, it was for all the patients who have failed every other biologic. Now we've got another one to try. And now I realize, no, we can start it earlier because it works really well for the type 2 as well as some of the non-type 2 as well. So
great. So, okay, next question. Maybe Flavia, you can start. This is a good one. How do you approach conversations about treatment goals?
Yeah, that's a good question. So I think kind of asking that whole patient-physician shared decision-making. So getting a sense for where they are in their disease. Definitely making it clear that it is the chronic condition, because I think the earlier you catch patients in their disease when it comes to chronic rhinosinusitis and nasal polyposis, a lot of these patients think it's a sinus infection, right? Give me an antibiotic, get me better, and off I go. And so some of these patients really need that extra time up front to discuss the chronicity. Some patients, if you call it it's almost like asthma of the nose or of the sinuses, then it's oh, asthma never goes away, so this is not going to go away. So I think that's the main thing, is really discussing the chronicity. And then from there, we talk about, for me, it's a little bit easier because do I refer to ENT? Do we start the biologic and refer to ENT? I always get ENT involved though, because I don't want to miss a patient who, may be a really successful surgery. And so I, kind of having that multidisciplinary discussion up front.
Yeah, and I think, it's important to talk to the patient to try to see what kind of goals they want to achieve. And actually, if you ask them a question, they'll know. And one of the questions I ask is, if I could just fix one thing for you today, what would it be? And they'll say, I want to be able to smell better, or I don't want to keep taking antibiotics every 4 months, or, I'm just miserable and I just want to get better, And so they'll tell you what they want to achieve. And then you work, and I think setting up expectations and, working with the patient to go over treatment options and having them buy into the treatment option helps the treatment become more attainable.
Those are great points. So I think this next question is a really important question. So what would be the end game of biologic treatment for nasal polyps? Study shows patients improve while on a biologic, but will relapse after discontinuing it. So if the majority of polyps were being treated by biologics, the cost of healthcare would be tremendous, right? So, getting at the point that, how do we select which patients to choose, and then, how long do patients stay on this? So I think the first point, we got it. This is really for patients with severe uncontrolled chronic rhinosinusitis with nasal polyps who haven't responded to first-line therapies, and then actually pretty extraordinary things like surgery, which is not a trivial therapy, right? And often have recurrence after that. That is often the patient who's making these decisions, and then thinking through patients with severe comorbidities. So a patient with severe asthma who needs biologic anyway for severe asthma, make a choice for something that would be beneficial for both their asthma and nasal polyps. So that is, I think, a pretty straightforward patient to consider biologic for. But I think the question about, what's the end game is that I do have conversations with my patients about, this is something you will be on for the foreseeable future if you have a good response to it. And the plan is for continuous use. And that doesn't mean that, maybe over time there may be some disease modification. We do see that with certain biologics can space out the dose after a patient has been doing well on it for a while. So, certainly that would be for a societal perspective, cost reduction. I don't know what you guys kind of see and think here, but this is a hard question. I think we all struggle with this.
Yeah, I agree. I think our talk tonight was skewed towards the more severe patient, and Joe mentioned that many patients do great with surgery, and that's it. That's all they need. So you don't want to start every patient on a biologic. But I think knowing who those more severe patients are, and hopefully we get better biomarkers to help with that, but certainly we already know that unified airway and the aspirin patients, like those patients, it's going to come back, right? So those are great patients who are at high risk and are at great, great chance of benefiting as well. And then the spacing out, yeah.
Yeah, and if you asked me 6 years ago what my answer would have been, once you're on a biologic, you're going to have to be on a biologic forever. Now, having biologic for 6 years and our experience with using biologics for nasal polyp, my answer is actually different now. And so actually, when I talk to patients, and I'll ask them, you'll have to be on a biologic for a long time. What do you really want to do? And most people say, I like to try to get off the biologic for the nasal polyp. And I think for asthma, getting off a biologic for asthma is not as easy. But for nasal polyp, we have to publish this data, but what we're seeing is, we've been putting patients on a biologic, and after they've had it for 6 months or a year, the patients are organically increasing the interval between the dosing of the biologic, and after a while they're on topical steroids, we have about 20% or 25% of people that eventually got off the biologic for the nasal polyp while they're on the topical steroids. Now, sometimes we require doing sinus surgery on these patients because the polyps haven't completely disappeared, so we may have to do surgery on them. But we've been able to get at least a quarter of the patients off biologic for nasal polyps. So that was something that I did not expect. So I think, I do talk to patients that not everybody can get that. I don't think ARD patients can get off the biologic, but there are some people who may be able to get off it.
And then looking back and seeing who were those people.
Yes, that's right.
So that we can proactively say, okay, you're probably in the subset that will be able to come off, so let's have this discussion again in 2, 3, 4 years or whatever, and get you down.
Yeah, do you guys want to help me write the paper?
That was it.
Oh,
that was, I think, the last question.
Right.
Yeah, those were great questions from the audience.
Well, thank you very much for joining us on this epithelial cytokine and chronic airway disease, a closer look at chronic rhinosinusitis with nasal polyp. So thank you very much.
Thank you.